Hello, this is Dr. Rachna Mazumdar. I'm a consultant endocrinologist at Fortis Hospitals, Kolkata and Bellevue Hospital. I would like to present a case about diabetes. Mr. A.B., a 58-year-old with a history of type 2 diabetes since 4 years with obesity, hypertension, hyperlipidemia, and obstructive sleep apnea. On physical examination, the BMI is stable at 32, blood pressure 130 by 82 millimeters mercury, heart rate 60 beats per minute. Laboratory measurements HbA1c 8.3%, eGFR 70, LDL 69, HDL 35, and triglyceride 250 milligrams per DL. AST ALT is 70 and 100 units per liter. The medications that he is on are metformin 1000 milligram twice daily, and lisinopril 40 milligram, metoprolol extended release 100 milligram, atorvastatin 40 milligram, and aspirin 81 milligram, all once a day. Patient profile. He has a short duration of diabetes. He is young and has no major comorbidities and no major complications that would reduce his lifespan. But he is also at a low risk for hypoglycemia. He would benefit from a more stringent goal. However, he is also obese, hypertensive, hyperlipidemic, has got raised liver enzymes, and an obstructive sleep apnea disorder. The ADA recommendation less than 7% is a reasonable goal for most non-pregnant adults. In addition to efficacy, following considerations predominate in determining the pharmacotherapy for him, such as the risk of hypoglycemia, weight loss, or rather to minimize weight gain, heart failure, ASCVD, CKD, and cost. Mr. AB is willing to start another medication, but is concerned because he sometimes forgets to take his pills and fears that additional pills will only make this worse. He does not want to have injectable therapy. Fixed dose combinations may improve patient adherence by once daily dosing, less complex treatment regimens, fewer pills, improved side effect profile, and adherence. Patients with type 2 diabetes commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common. Monotherapy cannot address these multiple defects and often leads to failure of maintaining glycemic control over time. Current diabetes guidelines encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. ADA recommendation: in appropriate high-risk individuals with established type 2 diabetes, the decision to treat with a GLP-1 RA or SGLT2 inhibitor to reduce MACE, heart failure, CVD, or CKD progression should be considered independently of baseline HbA1c or individualized HbA1c target. Empalina is available as first-in-class treatment in SGLT2-1 inhibitor and DPP-4 inhibitor combination group of drugs. SGLT2 inhibitor is a class of novel oral glucose-lowering agents that mediates glucose-lowering action by increasing the urinary glucose excretion via inhibition of the sodium glucose co-transporter 2 in the proximal tubule of the kidney. The salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of the disease course. DPP-4 inhibitor exerts its glucose-lowering effect by elevation of the incretin hormones and subsequent augmentation of the glucose-dependent insulin secretion and inhibition of the glucagon release. Combination of these agents has the potential to show the additive glycemic control due to their complementary effects. Empagliflozin cardiovascular outcome event trial in type 2 diabetes, EMPA-REG outcome reported that 3P MACE outcome occurred in a significantly lower percentage in the EMPA group compared to the placebo on top of standard care. In addition, CV safety of linagliptin DPP-4 inhibitor was further elucidated in the Carmelina and the Carolina trial. HbA1c decrements by Empalina 25/5 has demonstrated 1.81% HbA1c reduction at HbA1c baseline more than to 8.5 at 24 weeks in the metformin-treated groups. The benefits on glycemic control were maintained at week 52 in metformin-treated groups, and a higher percentage of patients achieving HbA1c less than 7% were reported for combinations. The combination offers a suitable component in strategy to achieve the target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in the overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP4 inhibitor is added, perhaps because of better glucose control, although other possible mechanisms remain to be investigated. In summary, Empalina combination provides robust HbA1c reduction, 2 to 4 times higher odds of patients reaching the goal, HbA1c, compared to individual agents with low hypoglycemic risk. Thank you so much for hearing. Thank you.